2, 1.
Okay, we're back. Thank you so much for your patience. We were just queuing up our next presenter. Dr. Matt Parisi is going to be covering high ankle sprains today. Unfortunately, his video is not working, but we were able to bring up his slides. Dr. Parisi is sports medicine, fellowship trained and board certified in primary care sports medicine. Before going to medical school, he graduated from Quinnipiac University with a degree in athletic training, sports medicine, and was a board certified athletic trainer. He's currently working out of Sports Medicine, New Jersey in Morganville, New Jersey. And he's a school physician for Colts Neck High School, as well as one of the covering physicians for Rutgers University Athletics. So Dr. Parisi, the floor is yours. You may just need to unmute.
Can you hear me now?
Yes, perfect.
Okay. Thank you, Diana, for the introduction. I was saying, I was actually speaking to Dr. Kristofiak earlier. You know, all the lectures are good this morning, a lot of information, and it's going to be a hard act to follow, but we're in the last 2 presentations of the morning, so hopefully we can keep the momentum going. So I'm going to talk about high ankle sprains today. First going over. Sorry, I'm difficulty moving the. Sorry, it's not moving over. So. Okay, so no disclosures. So the objectives today is to discuss the definition of high ankle sprain, the epidemiology, discuss the function of the ankle syndesmosis and relative anatomy, the examination findings of high ankle sprains, and discuss the treatment options to return to play and for high ankle sprains. So first, talk about a high ankle sprain or syndesmotic injury. This is an injury to the distal tibiofibular ligaments. Depending on what literature you read, it has about 1 to 20% of all ankle sprains and about 40 to 74% of ankle injuries in sports. Who's mostly affected? So it affects athletes more than the general population. Studies did show that is more common during competition rather than training or practices. It happens more in boot immobilized sports such as hockey and skiing, and happens more in contact sports, football, wrestling, rugby. Some associated injuries with high ankle sprains or syndesmotic sprains are OCD lesions, ankle fractures, mostly Weber B and C, as you could look how it goes into the syndesmosis over here. Deltoid ligaments due to the rotational forces of the talus, loose bodies, calcaneofibular ligament injuries, as well as tendon disorders. So just going over some anatomy of the ankle. So the ankle joint has 3 articular surfaces. So you have the talocrural area, so the ankle mortise. This comprises of the tibia, fibula, and the talus. This is a hinge joint. You know, the motion is in the sagittal plane, so a lot of dorsiflexion and plantar flexion. With this, the fibula takes about 1/6 of the stationary body weight, and in some studies it showed that load is up to about 10 to 30%. This load does increase with higher loads on the body, as well as lateral displacement or with the foot in dorsiflexion. The fibula does have some posterior lateral bowing. This is stabilized by the interosseous membrane, which is also transfers load from the fibula to the tibia during weight bearing during that. Then the next area is the inferior tibiofibular articulation. So this allows small amounts of rotation. This acts in the transverse plane. And then we have the subtalar joint, which is more of the calcaneus and the talus. And this does inversion, eversion, acts as a shock absorber, and acts in the frontal plane. So talk about the bone stability of the ankle. This is solely based on the depth of the fibular incisor. This varies in individuals. There were some studies that report that about 40% of people do have a shallow insura, and there is some thoughts that this does lead to predisposition to high ankle sprains. And then the anterior bony aspect of the tibial tubercle, this does add to the fibula being displaced posterior with disruption to the syndesmosis. Okay, so going to syndesmosis. So this comprises of 4 ligaments: the anterior inferior tibiofibular ligament, the posterior inferior tibiofibular ligament, the interosseous ligament, the inferior transverse ligament, as well as the interosseous membrane. There is physiological movement between the tibia and fibula, and this is believed to be inherently due to the elasticity of the syndesmosis. The syndesmosis is mostly stressed at extreme dorsiflexion as well as plantar flexion, but does function throughout the range of motion. The function of the syndesmosis is to secure the fibula against the tibia and resist axial, rotational, and transverse forces in the ankle. One of the athletic trainers I used to work with, Eric Nussbaum, he does a lot, speaks about the high ankle sprains, and he gave me this analogy that the ankle is like a crescent wrench, where you need that tension to apply that torque. So, this area over here is kind of like your syndesmosis. So if this is loose, you're not going to get any pressure, and it leads to some instability and other problems down the road. Talking about some medial collateral ligaments of the ankle, we have the deltoid ligament. This is a major stabilizer of the ankle mortise. The deep deltoid ligament actually limits some talar rotation, and if disrupted, you could get lateral displacement of that talus, so it keeps on pushing laterally on the fibula, causing spread to that syndesmosis. Next, we have the lateral collateral ligaments. So this includes the anterior talofibular ligament, the posterior talofibular ligament, and the calcaneofibular ligament. Okay. So kind of going to the high ankle sprains. First it's important to take a history. How did it happen? Are they able to weight bear after? Where is the pain? What is your pain intensity and quality? And does the pain radiate anywhere? Typical mechanism of action is the external rotation and hyperdorsiflexion of the ankle. The talus rotates, fibula rotates externally, moving posterior and laterally. It's mostly involved in contact type injuries, but can happen non-contact as well. There's also some studies that show that injuries can happen from axial forces as well. So inspection, this is very important to, we don't always have the luxury of being there when our patients or athletes get hurt, but if we do, we can look at what play happened. How did their ankle roll up? Is there any swelling? Is there any bruising going on? Are they able to ambulate right after the injury or when they come to see you in your office? Palpation is another important aspect of it. So knowing your bony structures and soft tissues is important, and always make sure that you palpate above and below the joint. It is important in these type of injuries to palpate the proximal fibula, as you want to rule out Mason-News fractures. So we have a picture right here. So as you can see, it's a fracture of the proximal fibula. Another important part of palpation is their tendinous length. So you begin at the distal end of the fibula, palpating to the proximal end of the tendinous along the syndesmosis. In cadavers, the interosseous ligament was found to be around 5 to 6 centimeters. So if tenderness at 6 centimeters, expect a high suspicion for high ankle sprains. There have also been studies that show that this could actually predict of total days of disability based on the length. Some special tests is the Kliger test. So this is forced dorsiflexion and external rotation. Next, we have the single leg hop. So this is a progressive testing. So first you want to be able to make sure that the patient could go up on 2 toes, then do a single leg toe lift, then do a double leg hop, and then do a single leg hop. There was a study that Dr. Gatt was actually involved in looking at high school athletes with high ankle sprains. They found 354 high school athletes with ankle sprains. 153 of them had just lateral ankle sprains, while 161 had lateral ankle injury with some proximal tenderness. With the single leg hop test, 5 out of the 153 with the lateral ankle sprains alone weren't able to complete the hop, where with the syndesmosis sprains involved, 161 out of 161 of the athletes were not able to complete the single leg hop. Next, we have the squeeze test. So what you would do is you compress at the mid-calf. This causes separation distally at the joint. If this test is positive, it is predictor of a longer return to play. Another test that you could do is the stabilization test. So basically, you are taping proximal to the ankle mortise, and this will reduce pain. I'm going to some imaging. So first, before we kind of run to go get any X-ray, you want to review your auto or ankle rules. So this, there's a high sensitivity and specificity for ankle fractures. So typical imaging that you want to get would be AP lateral and mortise views. Some things you're looking for are decreased tibiofibular overlap. So so that would be this area right here. So on a normal AP view, you expect to see greater than 6 millimeters. On a mortise view, you expect to see greater than 1 millimeter. You look to see an increased medial clear space. So that would be right here. Again, normal is less than or equal to 4 millimeters. And then you look for the increased tibiofibular clear space. So that would be this area here, and this is less than 6 millimeters on both AP and mortise views. Sorry. You also want to make sure that you get a full AP and lateral tibia and fibula if there is proximal tenderness, again, to rule out the mesonuclear fractures. If there is a high suspicion or there is thoughts to be instability, you want to get external rotational stress views or gravity stress views. And sometimes it's always good to get a contralateral view, just because if you're just questioning the spacing that you see on the X-ray, you want to compare it to the contralateral side, because that could just be their normal anatomy as well. You can always get a CT scan if there's a high suspicion with normal radiographs, again, to look at any fracture patterns, as well as post-operative assessment for reduction after fixation. MRI is also a good test and is highly sensitive for these specific type of injuries. Now going to treatment. So before you decide to treat, you have to see the level of severity of the injury. Looking at different research, there aren't really great grading patterns for these type of injuries. So this is one that I found in one of a talk and by Mr. Nussbaum as well. So if you look at first degree, you call these more of a low-high ankle sprain. So there's less 6 centimeters of tenderness. There's some tenderness over the anterior inferior tibiofibular ligament. They can't hop from toes. They do have normal X-rays. These are most likely associated with lateral sprains and laxity. Typically, you'll non-weight bear these patients for 2 to 4 days, and about 5 to 7 days of disability is kind of where they're at. Now, a second degree is a high ankle sprain, so they have a 6 to 10 centimeter of tenderness. Usually, there's more than 2 ligaments that are involved. They can't hop. It is a good idea to get a stress view. Consider MRI. Again, non-weight bearing for 4 days, and these typically take about 2 to 4 weeks of recovery. Consider arthroscopy. This second degree is kind of more the gray zone of how we're going to treat them, whether it's operative versus non-operative. And then we have a third degree. So this is, higher than 10 centimeters of tenderness, suspect diastasis. There's probably a deltoid injury or a posterior injury as well. X-rays with stress view are always good to get. MRI, again, to see the extent of injury, and also consider CT scanning. These most likely are going to go for surgical fixation. This was another classification that I came across, and I put this in the slides because it's going to go into one of the studies I'm looking at later about treatment options. So again, grade 1, 2, and 3 based on the significance of tenderness, swelling, and instability. So most of the times we could treat these patients non-operatively as long as there is no instability or fractures. So typically we start off with non-weight bearing and physical therapy. So going to non-weight bearing, so there's different ways. Some people use posterior splints, casting, or boots. This study done by Kadaki in 2008 looked at the mobility of the ankle in 5 different immobilization devices. They found that with a fiberglass cast, you get 8.4 degrees, while in a pneumatic walker, you get 15.4 degrees of motion, and in a DonJoy Max walker, you get 19.1 degrees. This is important just to see, how well we could stabilize our athletes during that initial time period. So this is one of the rehab programs that we came across. Again, this is by Nussbaum. This was put in the American Journal of Sports Medicine 2001. This is considered a conservative but aggressive approach to therapy. So if you look here, phase 1 is in days 1 to 4. So these patients were placed in a posterior splint at neutral position. The splint was removed daily for rehab purposes, where they would do light progressive resistant exercises manually, as well as light passive stretching. You could also do cryotherapy, e-stim to manage pain and the swelling. At day 4, the splint was removed and they were put in partial weight bearing as tolerated with crutches. At this point, we increased the intensity and duration of the rehab. We began progressive resistance, proprioceptive exercises, and functional training. Also, we started switching to thermal type therapies. Phase 3 starts after the athlete could do 10 single leg hops without difficulty. Functional testing was then done to determine return to play. The athletes were taped or braced, and we started doing exercises like sprinting, cutting, figure eights, and this would also allow us to see if they could return to play. They were only allowed to return to play if they had full range of motion and 5 out of 5 muscle strengthening. Typically with this, this is about 60 athletes that they use. So the average days missed were between 5 and 24. It looked like most people came back at about 13 days to return to play. One thing to be aware of during the rehab process is any posterior ankle pain. This could be an indicator that we're moving too quickly or the patients are doing too much. So at this point, if they're experiencing posterior ankle pain, just tailor back your rehab a little bit, let them rest and let them calm down, but continue progressing as they could. It was with this study that it showed that, allowing for protection in the beginning, but doing therapy right off the bat was, decreasing muscle atrophy. It was, increasing tensile strength of healing muscles and surrounding tissues, as well as encouraging lymphatic drainage. One thing this did show, heterotropic ossification is associated with syndesmotic sprains and recurrent ankle sprains as well. In some studies, they were shown to be up to 70 to 90% of all syndesmotic injuries. Based on that rehab program that I showed you before in that study, only 1 out of the 60 athletes showed heterotropic ossifications at follow-up. Next, we have operative indications. So again, like I said, instability, refractory to conservative management, as well as syndesmotic injuries with fractures. So there's 2 different types. You can either do a syndesmotic screw with fixation or a syndesmotic fixation with suture button. So just looking at the difference between the 2, this study looked at 10 studies, about 390 patients. Basically, the scores were pretty much the same of the American Academy of Foot and Ankle Surgery. scores 91%, 91 points with the suture button, as well as 87 with the suture screw at 17 months. No patient with the suture button had implant failure versus 30% in the suture screw. And postoperative complications were about 12.6% with the suture button versus 16.4% with the suture screw.
Dr. Parisi, just wanted to let you know you have about a minute left.
Okay. So again, those were all kind of just the same findings. It looks like the suture button is better for the athletes with less complications, earlier return to play for that. There. Sorry. So pretty much going over summary. So ankle syndesmosis helps stabilize the ankle and resist external forces. It's important to know your anatomy and structures while you're palpating. This could give you evidence of what structures are actually injured at that point. Using tenderness length over 6 centimeters, have a high suspicion for a syndesmotic injury. This will also help predict the return to play status. Conservative management for stable syndesmotic injuries. Need to be able to do a single leg hop before progressing to return to play, and surgery for unstable syndesmotic injuries. Thank you. Go Rutgers. Hope they beat Ohio State this weekend.
Thanks, Dr. Parisi. That was great. And I did see a few folks put some questions in the chat just about the slides for today's presentations. We will organize them, get them all together, and we'll send you guys a link, anyone that attended today, so that you have access to all the content that was presented. I do not see any questions for you, Dr. Parisi, but if you want to hang out a few minutes, some may come in over the chat.
Okay. Thank you. I'm sorry for the technical difficulties.
No problem. You did great. Thanks so much. All right, so we're going to move on to our final presenter of the day. We are, again, very happy to have JAG1 Physical Therapy as a co-sponsor of this event. We'd like to welcome Mr. Mike Evangelos, Vice President of Clinical Services. John Gallucci, who was scheduled to come join us today, unfortunately had a family emergency, so we wish him well. And we're just very thankful, Mike, that you could hop in his place. Trying to see here if I could see you. Does your camera work okay? All right, there you are. Hi, Mike.
Yes, yes. Good afternoon, everybody. Thank you, Diana. I'm happy to jump in here today.
Absolutely. You want me to give you a little introduction,
Yes.
Mike, or a drum roll here? Okay.
Yeah, go ahead.
All right. Okay, so Mike is the Vice President of Clinical Services for JAG1 Physical Therapy. He earned his master's degree in physical therapy from the esteemed Northeastern University program in 2004. He has since enjoyed rehabilitating a variety of different patients, including local high school and elite collegiate athletes, as well as professional soccer, baseball, and lacrosse athletes. He specializes in sports medicine rehabilitation, including soft tissue massage and joint mobilization techniques from the International Academy of Orthopedic Medicine and Mulligan techniques. His other specialties include neurological and vestibular rehab. Mike is a member of the American Physical Therapy Association. All right, Mike. Mike is going to be covering eccentric loading and reducing the rate of re-injury today. Go for it.
All right, thank you, Diana. Everybody can see my screen, correct?
Yes, good to go.
Okay, excellent, thank you. Okay, so eccentric loading, reducing rate of re-injury. So when I think about eccentric, I think back to when I was a young clinician, right out of school, and I started to treat athletes. To be completely honest, I did not really focus too much on eccentric coming right out of school. I thought a lot about concentric, athlete, making sure to rehabilitate athletes to be able to explode, jump, run, whatever it may be. Then throughout my career, rehabilitating high school, college, professional athletes, it became increasingly more apparent that the eccentric loading and training and rehabilitation is definitely as important, if not more important, than the concentric loading. So when it comes to basketball players, jumping, right? So jumping and landing correctly. When it comes to baseball players, especially pitchers, the deceleration phase, which is mostly eccentric, right? When it comes to soccer players, Football players, lacrosse players, when they need to decelerate, change directions, eccentric loading is extremely important. And if we don't focus on eccentric loading throughout the rehabilitation process, the rate of re-injury, no matter what type of athlete it's going to be, is going to be very high. So, physiology of eccentric loading. During voluntary contraction of the muscle, speed of contraction and ability to exert tension are inversely related. The faster a muscle contracts concentrically, the lower the tension it can generate. Tension in muscle fibers when lengthening is considerably greater than when muscle fibers are shortening. During negative work, which is eccentric exercise, the oxygen consumption rarely rises to more than twice the resting value. How eccentric exercise reduces risk of injury. It's all about neuromuscular control. So recent evidence has shown that eccentric exercise as a therapeutic intervention influences muscle morphology and targets unique alterations in neuromuscular control, influencing injury risk. Improper neuromuscular control appears to be a significant factor of primary lower extremity injury that can lead to abnormal knee mechanics during loading, which are the most predictive risk factors of those who go on to experience ACL injury. Now, this is a very, very interesting statistic. Actual reported re-injury rates range from 1 to 4 to 1 in 17 in ACLR patients, with a higher incidence reported in the first 2 years post-injury. Risk of injury increases because of neuromuscular control deficits seen in individuals for poor landing mechanics, deficits in postural control, and altered peripheral muscle activation from changes in the central nervous system, right? So as a rehabilitation professional, right, we have to really focus on that. It's so easy to give our patients certain types of exercises to work on strengthening on certain muscles, whether it be the quad, the hip abductors, the hamstrings, but teaching them that neuromuscular control and teaching them the biomechanics and reinforcing the quality of movement rather than quantity of movement or intensity of movement is so, so important. Eccentric loading for ACL rehab. ACL injuries can potentially result in limitations in range of motion, degenerative changes of the knee joint, and certainly muscle atrophy. Right? There was a study in 2011 which found that eccentric knee extension training was reported to be essential for restoration of the functional capacity of the ACL reconstructed knee due to findings of significantly larger concentric and eccentric peak torque deficiencies in the knee extensors as compared to the knee flexors. Progressive eccentric exercise implemented post-ACL reconstruction has demonstrated benefit to the following: volume and cross-sectional area of the quads and glutes, superior short-term improvement in quadriceps torque, hopping distance and activity level, and knee flexion extension range of motion during gait compared to a traditional post-op ACL reconstruction program. I'm not going to go through this entire ACL program, as Diana just said. Anybody who wants these slides can certainly get them afterwards. But generally, we're going from, level 1 where there's eccentric training and then non-surgical leg after an ACL in level 1. And then phase 2, we're starting some very mid-range, gentle, closed chain eccentric exercises for the involved leg, and then progressing from there through levels 2, 3, and 4 on the eccentric side. Okay, but basically you could see from phase 1 on the non-involved side, and then phase 2 through phase 4 on the involved side, eccentric training is going to be used and it's going to be progressed in order to prepare the athlete for that phase 4 where they're doing return to sport activities. Okay, hamstring injuries are very common in sports with sprinting demands, kicking, and sudden accelerations. We see it all the time in college athletics. We see it all the time in professional athletics. You watch baseball, football, soccer, whatever it may be. You see guys, girls going down with grabbing their hamstrings all the time, right? Hamstring injuries. And that's a lot of the time because of that lack of eccentric strength and eccentric neuromuscular control. Rehabilitative programs aimed at the prevention of future hamstring injuries are definitely recommended. Injuries to the hamstrings have been attributed to both intrinsic and extrinsic risk factors. Extrinsic risk factors are characteristics within the environment, many of which are not in the athlete's control. The greatest risk factor for this type of injury is contact with another opponent, which accounts for 44 to 47% of all injuries. Intrinsic injuries, on the other hand, are characteristics within each athlete, which may or may not be modifiable, right? So intrinsic injuries are that eccentric strength, that neuromuscular control, that hamstring pliability or flexibility that they have. So a great set of exercises that's used in Norway and Iceland are called the Nordic hamstring exercises, very appropriately named. So they have had very positive results among soccer players. And as I said before, elite soccer players from those countries report decreased hamstring injuries, maximal eccentric hamstring strength increases, enhanced optimal lengthening of the hamstring muscle, and improved ability of the hamstrings to progressively sustain loads. Peak hamstring torque was shifted to a more extended knee angle position after training with these Nordic hamstring exercises. We'll see pictures and I'll take you through them in a second. Since most hamstring strains occur during eccentric contraction of the hamstring muscles, increased torque in an extended knee position may reduce the occurrence of strains. While elite athletes are at the most risk, injury incidents may be impacted by level of play, exercise load, and standards of training. So we're going to go between this slide and the next slide here. So figure one is obviously, we all know that one. That's the self-stretch. Self-stretch is using support from a partner, a stationary object. These should be bent at the start, ankle relaxed. You're pressing your heel against the ground for 5 to 10 seconds. It's basically a contract, relax, self-stretch here to activate the hamstring muscles, and then relax and use your hand to extend your knee. You're going to hold that stretch for about 20 seconds. Okay, next is the partner stretch. Okay, the partner stretch here is actually going to be figure 4, not figure 2. Please look at figure 4 for that. All right, your partner raises your leg with the knee bent until you feel the back of the thigh stretch. Hold this position for a few seconds before you press your leg towards your partner's shoulder. Again, a contract, relax technique with the partner. You're going to hold for 10 seconds, then relax while your partner stretches firmly but cautiously by leaning forward. You're going to hold this position for 45 seconds, and you're going to stretch each thigh 3 times. All right, and then the next one is the Nordic hamstring lowers. All right, so you're going to see that here in figures 2 and 3, actually. Okay, so on that one, your partner holds your leg stable, leans forward slightly with a steady speed. That's the key, steady speed. It's very easy for your partner just to drop down, right? So you have to make sure it's controlled. Hold the back and hips straight. Try to resist with your hamstring muscles as long as possible until you lose your balance and fall on your arms. As you get stronger, make the exercise more demanding by increasing speed at the beginning of the movement, even by being pushed by your partner, right? So an external resistance there. Let the chest touch the ground. Use your arms to push up immediately until your hamstring muscles can take over the movement and pull you back up to that starting position. Okay, be careful in the beginning. Progress this one slowly. You're going to use 2 sets with 5 repetitions, and then you increase slowly to 3 sets with 12 repetitions. Okay. High-level ACL and hamstring rehabilitation. Exercises require little equipment for effective implementation. High-level eccentric focused exercise can be completed, including plyometric box jumps, eccentric backward steps, eccentric lunge drops, eccentric forward pulls, single and double leg deadlifts, and then the split stance deadlift, also known as the good morning exercise. Pictures are here. Obviously on the eccentric box jumps, that's all about quality of movement, keeping an eye on the hip and knee angle there. Okay, and then we can go down to the eccentric lunge jumps. And then the eccentric good mornings. Again, watching the angle at the hip here, and also the angle at the knees. And watch the control of movement she has going down versus when she's coming up. And then lastly, our forward pulls. All about control, neuromuscular control, and controlling the speed. Okay. Benefits of eccentric training. Even though eccentric contractions create more force than concentric actions, they use less energy. Faster muscle gains, since your muscles are strongest as they move eccentrically. If you want to push your limits, you have to work eccentrically. The greater metabolic boosts. Studies from the Strength and Conditioning Foundation show that slowing down the eccentric phase of your lifts can significantly increase your resting metabolic rate, the number of calories you burn at rest. More flexibility. Studies also show that those who performed eccentric hamstring exercises improved their flexibility twice as well as those who stuck with static stretching. And of course, and most importantly here, because of this talk, is lower risk of injury. Eccentric exercises strengthen not just your muscles, but also your body's connective tissues, helping to both rehab any aches and pains, as well as prevent injuries ranging from tendonitis to ACL strains. Thank you very much for listening. Open to any questions if anybody has any.
Thanks, Mike. All right, just checking the chat box here. Nope, I don't think anything has come in. If anyone thinks of questions after this, please send them my way. We can certainly, circulate them to the panel. I will be reaching out to all of our panelists today to get their slides, so look for my email. Mike, I appreciate your time today and for joining us, and big thanks to Jag1 for co-sponsoring this event and spreading the word. We greatly appreciate it.
Thank you for having us.
Absolutely. All right, so just going to spend a minute or two kind of closing out, seeing if any additional questions come in. One, I just want to thank our panel today. Everyone did an amazing job of putting their talks together quickly, efficiently. I think there was amazing content, and we really hope that all of you that have joined us got a lot out of today's program. Please keep an eye out. We will continue to do programs throughout the year. Definitely sports medicine grand rounds programs that are a little bit shorter. And then of course you can look at this time of year for, our annual symposium, as we're going to keep up with this every year. Additionally, we want to thank all our networks of professionals that have joined us today. It stinks I can't see you, but I do know that you're there. So hopefully we will get into a more in-person platform in the future. And we want to make sure you also are following us on our social media. I actually got something in the chat about professional opportunities earlier, and we have plenty. We have a lot of athletic training opportunities. I know there's some physical therapy recruitment across the system as well. So, check out our career page, and if you're looking to be part of something great and work with some of the folks you saw today, definitely keep us in mind. So I'm just going to kind of queue up to our panel here for some final remarks. So Dr. Krzysztofiak, I think you wanted to say a few words.
Yeah, I just wanted to really verify really quickly if there was any additional questions that any of the panelists who are left on can answer for our attendees.
Don't see anything coming in at this time.
Great. Well, I just wanted to thank all of our participants today, as well as everyone on the panel. Thank you guys for taking time away from your schedule to be with us this morning for system cleanup. So if you guys get any feedback forms, please give us your feedback. This is our first symposium. We're looking forward to doing this yearly moving forward. But just comments on the format, obviously being virtual. Hopefully next year will be different, but anything on the format, the content, anything you would like to see change or anything we did good, please let us know. And again, thank you so much for everyone involved today. We hope we're able to answer any questions and give a little bit more, insight to lower extremity injuries in competitive athletes. As Diana Toto mentioned, we will have sports medicine grand rounds coming up. We typically like to do those quarterly. And then again, our symposium will be held yearly. We also do other events that we'll keep everyone notified about. So again, thank you and be safe.
All right, thanks everybody. Please keep an eye out in the next week or so for information on how to receive your statement of credit for attending today's program. We look forward to seeing you all again soon. Take care.